Dear René, dear Peter, thank you very much. The time has advanced quite fast. I must admit, I wasn't sure what I should talk about getting this subject. Usually I always talk about TAVI and all the advantages of TAVI. And this time I think I will rather look into surgery in regard of this patient population and age. And to take over just the last speaker's numbers of TAVI implanted worldwide, 50 to 60,000, just to give you a relationship, it's about 200,000 surgical aortic valve replacements per year. 50 to 60,000 TAVIs altogether. All right, so I was wondering, what should I tell you about a 60-year-old device versus SAVR? And obviously, the question is, or what is missing here is the question mark, because it's quite a statement. So I went into, sorry, that's the right click. I went to look into, first of all, that should be a question we should discuss about. And I was trying to get an answer to that question. And my first answer was, of course, no. There is no way this patient should get a TAVI. This is a surgical candidate, and we'll see most through my presentation you will get that kind of an answer. And I could stop here, and then I could reach my train if the first speaker didn't try to mobilize the floor for 30 minutes. But nevertheless, we went on. So that would be my answer. Mechanical valve. Maybe a little provocative in this age group, but I think it's a very elegant, a very good solution for that patient. What I really think we should avoid is this kind of situation. This is not an autopilot thing that a patient decides about his treatment and final about his outcome. It's us in the heart team deciding together, integrating a patient's decision to what treatment is best for him. It's a balance between risk and safety as always, and that is what will give the best outcome in the patient. I was looking into long-term data about TAVI. Well, what best I found was 3 years, partner A, good results, nevertheless, 44% mortality in this high-risk population, but only 3 years follow-up. Then I looked at the guidelines, and I also looked at the surgical outcome, and you use isolated aortic valve replacement. You got a outcome of a mortality, third-day mortality of 2.9%, 2.8, 3.7, 2.9, so very low, excellent results. Obviously, this is only 30 days, and I looked at our own results. These are only patients above the age of 80, was done in 2000 to 2002, there were not that many patients at the time above the age of 80 that were included. So we're 161 patients, and I looked at our isolated aortic valve replacement with a 30-day mortality of 2.8% and a 5-year survival of 75%. These are patients above age of 80. And then I also looked at risk and said, well, what's the risk and what if we're correlating to the risk scores? And this is from the German Leistungsstatistik, and you can see here that surgery is well performing in high-risk scores, but I would like to draw your attention to this little part here, 10 to 20% Euro score. This is a 30-day predicted mortality of 10 to 20% in this group in the mean 13, and surgery is outperforming with 3.4 real mortality. So let's keep all this in mind while we go through the slides. And obviously, if you have a question, you always look first at what are the guidelines saying. Can we find the answers in the guidelines? So looking at the guidelines, we go quite fast-paced here. So one of the things is looking at mechanical valves, because obviously there is no mechanical TAVI valve, so there can only be tissue valves. So if I look at what are the indications for mechanical valves, I will include the TAVIs anyway. So desire of informed patients for not having a mechanical valve, for example. Risk of accelerated structural valve deterioration would be a reason to put a mechanical valve in, what obviously is absolutely true for younger patients. Let's see if 60 years is a younger patient or not. And considering patients above the age of 60, this has changed from the previous guidelines. It was above 65. Now we're between 60 and 65. We can start thinking about a tissue valve. So it doesn't really give me an answer to what to do with that patient. And I looked some further and looked about the TAVI guidelines. Heart team, of course, cardiac surgery, severe symptomatic aortic stenosis, not suitable for aortic valve replacement. Aha, so if a patient is not suitable for aortic valve replacement, then TAVI might be an indication for a patient of 60 years of age. Obviously, the high-risk patients who TAVI is not favored, that's the same kind of answer in a little different wording. Now, what I did a logistic Euroscore risk calculator and just added, first of all, 60 years and aortic valve, 1.6 Euroscore. logistic Euroscore risk. Okay, let's add some more risk. COPD, let's add some peripheral artery disease, 4.9%. Well, still not good enough, my God. And then I added some extra here, ejection fraction of 30 to 50%, 7.2%. We're still not getting there. If you're 60, you need to be a really sick dude to get to be allocated to TAVI. And finally, I also put pulmonary artery hypertension. I got a 14%. Wow, now we're talking business, 14%. So that might be a good candidate for TAVI. Why not? And then looking at the expected and observed mortality, also Deutsche Leistungsstatistik 2010 of TAVI. You remember the first slide? And this is the same kind of view for TAVI. We have 14.3. Before I spoke about 14.4% of predicted mortality. We get to 7.1%. So we're outperforming again with TAVI. But don't forget, the slide I just showed you a little earlier was surgical results, 3.4% comparing to 7.1% for this kind of 14% that looked like quite a high risk. So also, there was no real answer to what to do except to go for surgery. Then I looked at age. What does age mean? Is there any kind of definition? Let's have a look. World Health Organization. Well, there's no general agreement on age. Well, okay, thank you very much. You helped me so much. But then I found any age above 50, but that was a definition in 1875. A little further, well, 60 to 65. This was a definition from 1979. And if you think about pension retirement plans, this is all about 65 in most countries for men. So I looked at what's the life expectancy. Well, in 79, we were somewhere here, but now we're in 2013 and 2011, life expectancy 84 to 80 years. So again, rubbish. You can forget about definition of age, etc. So I looked at what's supposed to be your expected life if you're 65 years old. That's the closest I got to 60 years. Well, damn long, 17 to 16 years in 2008. With the progression we are now 4 years, 5 years later, it's probably going to much more again. So not really an answer. I looked about what about tissue valve? What's the rate of degeneration in this kind of age population? 51 to 64 years. 78% have freedom of deterioration at 12 years, but only 60% at 15 years. Now we know they all live 17 years. They will outlive their valve and they will need a second tissue valve. Well, okay, it's not too bad. Valve and valve TAVI can be done. We will look at this a little later on. Frailty, look at frailty. What about frailty? That could be the reason why I can do TAVI in this patient. So, obviously, this is one of the risk scores, one of the earlier ones. 2001 has been early adopted, but only later by the cardiologists and cardiac surgeons. It's a general surgery. It's a study that looked at 60 patients of 65 years and more looking at frailty. And I will just keep it short here. And they looked at, they got the result that scores of 4 to 5 is high frailty, had 20 times higher risk of going into an elderly home for elderly care than to be discharged home for cholecystatic or cholecystectomy, easy surgery. Well, okay, so that's good. I can find patients now above 65. It's still 5 more years more than my goal. But looking at the study, we realized that actually there were only less than 5% of patients that were included with that kind of frailty in this study between 65 and 75 years. Again, no real answer to my question, or rather an answer towards surgery. Hostile chest, and I think that's where we're going to find the reason why we could find a patient with 6 years of age to do TAVI. And I skipped this patient, but just briefly, it's a patient I presented 2 days ago here at the same meeting. Status post-aortic type A dissection, got a composite graft, got an endocarditis, got a shell-high graft, dialysis stage 4, not a very attractive patient. And this one, only 56 years of age, left ejection fraction of 40%. And I was a candidate. We performed TAVI. Porcelain aorta, that's another reason why in this patient we went for TAVI. You can see the severe calcifications here. And it went through the heart team, of course. The heart team looked at the patient. We discussed many times about the patient and family. Eventually went for a core valve implantation that Prêtre Wenaweser performed with an excellent result. So, yes, I found one patient to present. But I already said, what about valve in valve and what about reoperative surgery? Quite a risky procedure to go again and replace another valve. We looked at this data as well. Predictive mortality, 19.9%. But look at our own Bernese data, real mortality, 3.8% for aortic replacement of an aortic valve. So this also not justifying TAVI. But then looking at valve and valve registry, 450 valve and valve TAVIs, and I just point out two positions here. Initial device malposition was 11% reported by the investigator of this study, and efficacy concerns high rate of elevated post-procedural aortic gradients of more than 20 millimeters mercury mean in 29% and in 2.7 over 40%. So it's not just as easy as that to say, put a tissue valve in and then go for TAVI. Again, think first. Now I have the two last slides before I get to my conclusion. This is a chart I've drawn about TAVI intervention, a map on how TAVI, all the TAVI segments that could be of interest. And there was one point that was reported to me from persons from the third world. And they actually said, look, your patient population is totally different than our population. Our patients are 25, 30 years of age, have aortic insufficiency, aortic stenosis, what to do, ladies in childbearing age. Wouldn't that be an indication to go for TAVI? So this is not 60 years, this is 25 to 35 years. And well, I'm really not sure, I don't know what to say. I think all the indications don't point that would be correct, but if you think about their vision, going for a TAVI, having your baby, and then going for a mechanical valve replacement, for example, might not be the worst thing in the world to do. I'm not saying this is our opinion, just saying many people think about this in countries with large patient populations having aortic stenosis and aortic regurg. Now, what's the answer? Well, it's already said to you. The question is, what should we do? The answer is, don't go for TAVI in these patients. With very few exceptions, go for surgery in the 60-year-olds. Thank you for your attention.